it's my pleasure to introduce you to Professor Nederland von Bernasconi and Dr. Andrea Bernasconi, which are both clinician scientists specialized in neuroimaging of epilepsy, and both are co-founders of the Neuroimaging of Epilepsy Laboratory, the NOEL, the Montreal Neurological Institute. And their lab, well, as you know, aims to use MRI techniques to study cortical architecture and function in search for biomarkers of epileptogenesis. They aim also to understand the fundamental aspects of the disease processes while tailoring their analytical approach so it can be helpful for clinical decision making. And as you know as well, they have worked on automatic lesion detection, multimodal disease biotyping, and connectivity analysis using statistical and more recently machine and deep learning approaches. Thank you for being here. Okay. Who wants to start? Who has questions that might be burning?
I have one question. So, hi, my name is Carolina. I'm currently in New York. And my question is more about how to implement all these tools into a clinical environment and the clinical pipelines and processes. Obviously, these are research softwares used for research and not validated for the clinical use. However, I'm assuming there are clinicians that use them for the day-to-day patient evaluation and pre-surgical evaluation. So how do you implement, how do you kind of make sure, or like how do you address, how do you kind of make sure that clinicians use these softwares in your institution, and how do you kind of make sure that patients are okay with their clinicians using softwares that are not clinically approved?
Okay. Since this is a group discussion, let me turn back the question to you first and to the group. What is it, because most of you are clinicians, how do you deal with lesion detection in your patients? What are the tools you have in hand, and how do you use them, starting by just, clinical MRI and clinical evaluation of your scans? How do you deal with that?
So I'm not sure here in my institution in Mount Sinai what softwares they use. However, I know that there are a couple of centers in the world that do use some like these software.
What do you do specifically? Sorry, Carolina, what is your role? Are you a postdoctoral fellow? You're a clinician?
Yeah, I'm a clinician, but I do not do work with FCDs. So I'm not kind of working on that right now. I work with other. There is principally aging and neurodegeneration in multiple diseases, especially in epilepsy. So it's mainly a bunch of PET analysis, SWI, and diffusion analysis, mainly those. Yeah, but I'm interested in learning.
Yeah, so you're using already kind of.
Yes, yeah, I'm using a bunch of softwares. Yeah, correct. And I use them more in the research setting. So we don't apply, like the only thing that we eventually send to a clinical side is just PET readings and information that has some clinical validation and it's clinical important. And for these, obviously, we use pipelines and softwares that have some sort of extensive international validation and that have been approved by some institutions to be used in the clinical setting. But most of them say this is not ideal for clinical. This shouldn't be used in the clinical setting. So it's always a little bit tricky. Like, at what point should we actually communicate the data, or like, should we communicate with the patients the results of our analysis that come from softwares that, yes, they're very good, and for us they're very good, but they're not internationally validated. So yeah, I think that's a question that it's always there in the back of my mind. Like, is this kind of valid enough? Even if our metrics say, yeah, this is, it's specific, the software is specific, it's sensitive, it's all of that. It's a little bit, you always think like, is this valid enough? Should I be actually moving this into a clinical pipeline and taking decisions based on the results of a software that is good, but I don't know if it's valid internationally.
Okay.
Okay, so I think, you know, it's more than a question. There are several aspects to your comments. One aspect is the how. How do we translate? And the second is the validation. This is not exactly the same. These are two different aspects. Actually, in fact, the most fundamental one is, I think, the very first one. How do we translate? Because the translation is it's a very fundamental problem we were having all the time. So since we began, in fact, because in a sense, because of the setting we have in our working environment, we have a kind of a proof of concept of what is to be a clinician scientist. So in my opinion, every scientist should be clinician and every clinician should be a scientist. I don't make a distinction. If you study medicine, you are a scientist. What does it mean? A scientist is not somebody who is completely blinded to reality, and reality being a wish or a capability, an ability to help someone. And the same is for a clinician, obviously. You think scientifically when you do your history taking, your diagnosis, your location. So it's so combined, these two elements, that to me there is no distinction. So the very first principle we always debated and tried to demystify is the distinction between a scientist and a clinician. So that's a real tough one, because it's against the general organization of our activities and even the intellectual framework. Oh, I'm a scientist, I don't know nothing about clinics. I've seen scientists that are pure breed scientists that were supposed not to know anything, but with time, coming to the seizure conference, they were very keen to this. And the same in the other way. People that had no idea started to ask, what is the threshold? What is the p-value? A clinician that interacts with patients all day in the clinic. So it is possible. So it boils down to the initiative of every one of us. Because we do have, if you come so far as to do medicine, to do neurology, to do epilepsy, and to do or aging or whatever it is, you already have such a high degree of specialty that the distinction between clinician and scientist should not even be mentioned. It should flow naturally, this entity as a clinician scientist. So that is the first message we should convey, because we do embody this in a sense. If you're here, it's because you are a clinician scientist. And so I think that's the very first step of translation. It's a mindset by saying there is no barrier between what we produce in terms of technology and what are the potential and the real application of that technology. And that's what we try to do ourselves. And that is something that is multifactorial. There is genetics and epigenetics in this process, because it depends where you are, how you want to interact with people, what are your abilities. I can tell you for us, I have no, I don't know how to program. I don't know how to code, but with time, we develop the sense of the meaning of the coding. What are the ambushes? What are the potentials, and what are the pitfalls? Simply based on a day-to-day activity and troubleshooting, and involving actually more our clinical thinking as a clinician scientist into something we actually don't know much about, but we know what should be the end results. The validation, it's almost a mindful operation that you have in the scientific process when you look at every step of it. Every step must be watched as something that is constantly evolving and changing, and you have to pay attention, even if you don't know every detail about it. So that takes away the barrier of saying, "Oh, I don't know. As a clinician, I'm not supposed to know." It's not true. You can survive this. You have to have, however, a certain amount of people around you that you trust. So the human factor is very, very important. So team building is one of the solutions. And obviously, in some institutions, it's very difficult, but a team starts with 2 people. And I don't know, maybe David Dufresne can comment on that. Some people have an environment that allows them to do that. We were too. We were the privilege we had is that nobody of us were alone. So the core build team, it's the 2 of us. And then we try to find people around us, obviously with the benefit of being in an institution that had already the technology. But the more with time goes by, the more these softwares are available. So the technical part is not an issue. It's really not something, it's more about ethics of use of technology and the destroying the barrier of translation. And the third one, which is a very personal one, and I'm sure you agree with me because you're here, is demystify the role of electrophysiology in the whole business. Because this is not the only core activity we do, it's a part of the system. So these to me are the 3 elements. So to come back into the translation that we did, we actually did it ourselves. Every lesion we see, we have looked at it on the MRI, we look at it, we agree on it, we trick each other, we find yes, no, yeah, oh yeah, no, you see, you didn't see that, but I saw that, and when we agree, so we come to an agreement, we validate it with our very basic tools that are not that far from anything else than simply modeling the very basic characteristic of anomalies in FCD, thickening, blurring, gradients, changes, very easy. And we validate it with our visual impression, being very aware of the barrier of the non-visibility. We don't cross that level. And then we give it to more sophisticated algorithms where we have the core validation and other stuff that appears. And that's where we try to attach a degree of confidence. So our procedure, a stepwise procedure, is very careful, again, dictated by the conscious behavior of a clinician and a scientist together. So that's what I would say, no?
Yeah, if I can add something. You know, validation is really a big word, and I'm not sure there are many or any tools that came out from pure research, particularly in neurology, in, you know, imaging tools that actually are validated as of FDA validation or whatever other norm of validation there is. It's rather the good sense. People like us have worked years, tens of years, 20 years, 30 years to try to figure out good ways with histological validation, visual validation, not out there in organizational validation, to build things that are clinically valuable. So I think this work can be taken with kind of confidence and trust in the community, particularly at the level where you make it open to people to use. It means that you have done your work in making sure that that's not a dangerous thing to put out there. Now, obviously, it demands knowledge to be used. You cannot take the same easy software like the one we provided to all of you with an explanation on how to use and say, tomorrow I'm going to apply it, and not say, but I don't understand, there are all these blobs, but what does it mean? How is it that these people say this is a good software? Well, there are steps to go for you as those we went through. And these are documented. They are explained in papers, in every type of publication that we put out there. So this is not a complicated thing. It can be done. The reason I was asking, what is your environment? What's the level of help you can get? And as Andrea was saying, team building that you have, each one of you in your organization, because this will define how far you can take things that have been pre-digested for you. Okay. Yeah. Now, another thing is that we always talk about validation for imaging tools. Exactly. I want to see a validation of people who would say that electrophysiology has been validated. What's the validation to put electrodes that each send, that each send, that each send, that each send? But no one comes and asks, what is the validation for that? So already there, I think we should take these barriers off and accept that imaging, electrophysiology, and any other tools that are available in the pre-surgical evaluations of patients with epilepsy, they actually should be taken at the same level. And non-invasive should prevail invasive. So there, I think we put the definitions where they belong. And it kind of opens up to have an open spirit to novelty. Because I think with imaging, there is novelty. I don't say what I think about the rest, because there is also novelty, but it's not our domain. But definitely, I think these are it should make you feel good about things rather than stress you.
I think also the validation, there is the, the notion of a rubber stamping of things that we do, okay? You have a software, there are a few for volumetric, for example.
There are some.
There are a few that are FDA validated. In a sense, is a bit of a trap, this kind of validation, because on one hand, to validate these things, you have to lower the level to such an extent that it becomes almost trivial.
Yeah.
I don't say that volumetry is trivial, but it's really, really something that has to, we used it like 25 years ago, and now it's proudly validated. Yeah, okay. What does it mean? Validation doesn't mean a infallible tool or a useful, totally reliable, totally powerful,
accurate,
and accurate tool. It doesn't need that.
Blindly.
It's a bit of a scam to package this in something that you can sell. So, and every change you make, you have to start all over again. So there is a lot of hindrance for translation. That's why when we said initially, you embody the translation, is because what we have done is to take this responsibility and say, okay, I apply my tool, but I give back a clinical translation. I take the responsibility as a physician to say there is a lesion here, you should be careful and look at it. Even against radiologists, I say there is nothing. So there are different levels of responsibility, and that is something you have to work out locally, because you can be silenced in a week if you don't agree with your radiologist. So you have, again, to have another branching of team building and building a certain degree of diplomacy, confidence.
Yeah.
We were lucky that our radiologists were extremely busy with interventional stuff. They look at the images, they say it is negative, we get back the report, we go back and we rubber stamp a addendum. But this is not always possible. And financially, I'm not necessarily compensated. So there are a lot of levels that you have to compromise to come to this translation. Yeah. And the validation done as a tool, obviously they should be validated, some of the tools, but I don't think is the barrier for translation.
Right. No. And the first validator is yourself.
Yeah, that's why, in our opinion, education is the first step, together with embodying as a epileptologist, having a good sense of I gain my salary by reading EEGs, not MRIs, okay? I read EEGs, I see patients, it's not that. But the future, it should be, the epileptologist should have the same competence in EEG and imaging. And imaging is so much broader that it's a bit scary. EEG competencies are relatively limited compared to the one you can acquire in imaging. So I do understand that there is some reluctancy, but resistance is futile.
Perfect. Thank you very much for the extensive reply. That's really useful.
Yeah, I think it's also very important to say that, as you said, these are tools. So as any tool, you have to apply reasoning and clinical reasoning to it. Because if there is no if there is no clinical correlation, what you're seeing probably is not responsible. What the output of any algorithm or pipeline is not going to be, because of course these have false positives, and so you need to like use it in concordance with the clinical
With the rest, of course.
Yeah.
And if I can take it a step before, even really, 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 it's not fancy, but your best friend are your eyes. It's your visual analysis of these MRIs, and good MRIs, good protocols, easy protocols such as the harness protocol are really your first friends. If you can go the first step or barrier of being able to look at these images properly and to be able to see big to medium size lesions, validate that with the tools, because this is the first validation. You validate with things that you can see with your eyes, that you know these are patients who are going to surgery, they are going to come up with a histological results. This is your first validation, but really you have to go with the visual analysis. Once you're good, you're gonna see the small ones. Really, there are very few lesions that we did not see with our eyes. Where they were very subtle, we had a doubt. It is the software that showed us an area that kind of would make sense with the rest of the story. We went back to the MRI and we said, oh my God, we missed it. It was there. So all of these lesions are there. The notion of non-lesional is really so relative to your level of knowledge that it should not even be discussed. So it goes really from non-lesional here, it's not non-lesional here, non-lesional is not non-lesional here. So it's too vast to be even discussed. So there are all these lesions, medium, small one, that you can miss and group them all into, oh my God, I have all these non-lesional cases, whereas they are not non-lesional in the hand of your colleague, on someone else or someone else. So there is hope. There is always hope, and there are always things that can be done with relatively small how do you say that, tools or means from on your side.
But yeah, I think the most important thing is that you are representing and taking this challenge of translation.
Yeah,
it's not bi-directional. You cannot expect that a pure scientist as the takes on the challenge of giving you an answer, a clinically usable answer. He will always back off and say, I'm not a clinician, I can say things, but
yeah.
So the only way it works is that you go there, you take what you need, you make it in the context of clinical, because, even putting it in the context of clinical observation, if you critically reevaluate the level of confidence that we have in our clinical inferences, you could start arguing that it's relatively low in terms of replicability among colleagues. We find consensus at some level, but there is a price to pay in many instances. Again, the way we implant people, what is the yield of that. We basically ditch 90% of data that we use in telemetry, video EEG. We look at it, but in a very superficial way. Hopefully now machine learning will help for that. So that's what we're saying. Probably there is hope to come, and what we call today false positive is maybe something we just want to ignore, and is actually part of the picture. Heterogeneity is not your enemy. It could be actually a friend. So all these things will come, and technologically they are already here. The problem is that epileptologists need to push it again a bit more and say, I want to take on this. Because the EEG is in the pocket. I mean, it's relatively standard. If you implant, it's even easier than scalp EEG somehow. But the conceptualization or the standardization of SEEG is very weak. And despite that, we build all our castle of validation based on that. So if you want to try to find weaknesses in this process, I am assuring you there are. Mm-hmm.
I might have another question. When we see which one of the maps that the texture analysis gives, do you think is more informative? Because, for example, we have the relative intensity and the gradient map, but do you think one of those is more informative, for example, for detecting maybe more subtle lesions? Because, for example, we know from the literature that, for example, other softwares like MAP18, their junction map seems to be more informative in detecting focal cortical dysplasia. Would you say that in your texture analysis, does it happen the same?
Well, you know,
yeah, we did have a kind of a junction. The junction map is basically the sum of two. It's putting 2 or 3 maps together.
It's replicating what we did in Annals of Neurology 99.
Yeah, we did have
which was the original paper on the texture analysis, but we dropped it
many years ago,
yeah.
And we had also a thickness map, and we used to put them together and get an average map, if you want, of all these different features. But at the end, we dropped it. First of all, because thickness calculation on volume is a bit tricky, and there is a lot of problems, partial volumes and things like that. And secondly, each map has its own information, particularly that based on FCDs, sometimes you have more intensity problems that would come out more nicer on the relative intensity map, whereas some FCDs really are characterized only by blurring, and there is not much changes in intensity inside of the lesion itself, and there the gradient map is more useful. But because you have the chance, or you can have the chance of viewing the T1, the flare, which is very, very important modality, together with these maps, I think it's your eyes that should do this integration, because you do not want to kind of downplay the one modality versus another one. We kind of like to look at them, and it is true that sometimes it's one of the two that are more speaking, if you want, more showing more anomalies than the other. But frankly, I think they are all useful, and they all have a specific information that you don't want to lose.
Yeah, I think every lesion has a bit its own profile.
Yeah, exactly.
And you know, they seem to have, even within the lesion itself, local regional
yeah.
Combinations of these things.
Yeah.
That's the very first step. In a 3D inspection, it's very difficult to appreciate all this at once. And that's why if you combine this into a summary of some sort, you have to pay the price of reducing your sensitivity to some extent. So again, then you see that's where we have these 3 basic features, but it's impossible there aren't more. And in combination, then you hit the wall and you can't see. So that's where quantitation and contextualization of the findings comes into play. And there is the threshold where you have to let go, take a deep breath, and let machine learning deal with this. Then you can recover it in the context of your clinical impression. But again, it's an impression. So that is where we come into play. As a physician, you are paid to have impressions. So you attach your degree of confidence. So that's where we come to validate these things. But we have to take this responsibility ourselves.
If you want to take advantage of the profile of lesions, their heterogeneity, because this is a fact and it has been shown histologically by the convergence is good if you have the same anomaly. Then when you put them together, it enhances. But if you have differences, I think, and you can look at maps or any type of modality separately, I think you gain more. Yeah.
So we should start. So we should start maybe looking for some normal MRIs with doing the analysis, the texture analysis on normal MRIs, and then probably also use it on the.
Well, you know, we have
done this initially.
We have also shown that the FCD, they do share characteristic of cortices that
some normal cortices.
Yeah, you know,
like the central.
Yeah, because they seem to occur also in cortices that are already presenting the features of FCD to some extent. They're more blurry, they're thicker, so they tend to occur there. And I'm sure, I don't know, but you know, these lesions don't occur in random places. They have preferential locations, and this to me has different levels. First of all, it's architectonic, and secondly, by all means, is genetic. So these are the two pillars that promote the location. The missing link here is how this is expressed clinically and electrophysiologically. So I think we do have an advantage in that respect conceptually, because one has to retrofit the clinical semiology and the electrophysiological signature with the genetic and structural MRI and maybe functional MRI characteristics.
I think for the texture maps, we did do this work a long time ago because we had to validate our findings and show that really there was a great specificity in these lesions. But you can look at these maps without needing to have healthy controls. And you should try to use them with obvious cases, because this is what you're going to see really how the lesion highlights with respect to the rest of the brain. Primary cortices, primary motor area, visual areas, auditive areas, they all have a lot of white matter tracts going in them. Therefore, the appearance of the gray matter is more hyperintense, like FCD, and there is a blurring because of this white matter entering the gray matter. There is a gray-white matter blurring. So these mimic FCD. So if you do get these maps, you look at your relative intensity map and your gradient, exactly in these cortices, you're going to see the features of FCD. So you have to be careful, particularly when lesions are close to these areas, to make sure that you go back to your original MRI, the FLAIR images, and you're sure that this is indeed an FCD. There are other characteristics, thickness and things like that. But yeah, and the fact that the sulcus is deeper where the FCD lesions are located. So there are always other signs, but you could have controls if you want, but you can also look at these maps without needing healthy controls, but sometimes it's difficult clinically to have healthy controls. So particularly for FCD detection, you really are going to a very specific areas, again, together with your clinical information. So you can also learn this way to use this map.
Okay. Silei, please.
I think she has a question. Yes.
Yeah, hi, I'm Silei. I'm from Malaysia. Actually, I've been practicing on reading MRIs using this texture pipeline, I think about a year ago. But I think that time the version is not compatible with my Mac OS version yet. So anyway, I managed to pick up one very subtle central sulcus FCDs using the texture pipeline, which is there when I go back to look at the MRI itself.
Okay.
And we operated on the patients anyway. So my question is rather operational. So when I use the register to view the maps, number one, how do I enlarge the images on the register?
Yeah.
And number two, I find it sometimes very difficult, especially areas when the gyri are very crowded, areas, for example, the orbitofrontal region.
Or also midline.
So maybe the interpretation is actually a bit difficult there. Any tips to sort of clearly differentiates whether or not there's actually abnormalities in that area? Not only orbitofrontal, I think temporal pole as well.
Yeah. Yeah, these are temporal pole is another area that is difficult to maybe discriminate between normal cortex, normal gray-white matter interface and the lesion. But I think this is really, if you have good quality scans, really good quality 3D 1 by 1 by 1 millimeter. I don't know if you work with children or adults, obviously in children. Adults, okay, so they can stay quiet in the machine. If you use a good quality MRI, I think with time you again, it's always a combination of things. Your evaluation, your level of expertise, how you use these maps, and your clinical, EEG and clinical semiology. If you put these together, you just can get better. Obviously, it demands time. But there is nothing magic, because the higher is the resolution of the MRI, the better you stretch these areas, such as the midline, such as the area, the orbitofrontal temporal pole. These are difficult areas to look for lesions. Oh, I mean, in children, there are lots of lesions in these areas, but they are big. So in some way, it's easier to see them. But in adults, that's why they get operated and then they don't come back as adults. But if you have someone who comes as an adult and has a temporopolar FCD, first of all, they are rare. So that's the good news. But then it makes it more challenging to find them. And you have always to make sure that it's not a ganglioglioma, that it's not associated with a severe case of hippocampal sclerosis and things like that. But there you really have to work out the quality of your MRI and your expertise in the region. Now, if you use Register, which I'm very happy people do use it, because it gives you this possibility to put all these maps beside each other and really use them sync. I think that the zooming depends on the mouse you use, for example. And you have to find out on your keyboard, because every computer and keyboard and mouse are different. Either is shift and the middle, the wheel, or any other one. But there is a possibility of zoom them to make them big. You just have to work around and see what works with you for you. Or you can ask us. We can ask Benoit or someone who has worked on that to get back to you. If you tell them exactly what type of keyboard and computer you use, we tell you how to use them. But definitely there is a way to zoom it, and you do need to zoom these images to see where some areas. Okay, yeah.
Okay. I'll try a bit.
The other thing that I find obviously not very useful, but fundamental, it's to have a team. And as I mentioned before, the very basic team is 2 people. So having a companion, it's always good. It's good to evolve with somebody. So you look at your thing, he or she looks at
Yeah, that's
the exam,
true.
and so then you compare. It's the very first step to reassuring yourself, and because by myself I wouldn't have seen some lesion, but it happens, you know.
When we
It
spend
happens
time
that
to look
sometimes
at them.
she spends 20 minutes and I open the thing, it's there, and vice versa.
Yeah.
So, you know,
Well,
it's
sometimes
useful.
you don't have someone else, then you just rely on yourself, and you just, by looking at these images, there is nothing special about someone versus someone else. It just depends on your determination and, you know, your discipline to look at these images. But I promise you, by experience, you can get really, really, really good at finding these lesions. And it's very, it gives you a lot of satisfactions when you see them,
Of course.
because you change people's life. Really, you can change it. And there is nothing special.
Yeah,
about it.
and there is also the interesting aspect that sometimes, as I just mentioned, sometimes it's
Yeah.
almost irrational and intuitive. It's
Yeah.
not luck. I think it's just the usage of our peripheral
Yeah,
integration of information
yeah,
that you just, oh, it's there.
yeah,
Because there are features that maybe you don't necessarily systematically look for the thickening and the blurring,
yeah,
but you know where to look deep in the depth
Yeah.
of sulci in particular areas.
yeah,
You know, I think it's a bit of a vicious circle. Cortices that have the tendency to look like an FCD are thicker, blurred cortices because they have their intrinsic degree of energy consumption, network abilities.
Yeah.
They have a makeup that is complex.
Yeah.
In the same token, they are fragile. So you don't have many FCD in the primary motor cortices simply because they seem to be more resilient.
Yeah.
Somehow. It's maybe a bit of a fantasy, but I think there is some truth. And so you already discard a lot of area that you shouldn't look at. So when you look at it in axial, because that's where we start, we always look at bottom of sulci and we look at the frontal lobe.
yeah.
Forget about the occipital, the rest. Doesn't matter, depending
Unless
where
you
you have a perfect clinical
Yeah.
visual scotomas or hallucinations,
Yeah.
whatever you have, you know, but that's some of the principle, but
Yeah.
and
Something else, sorry,
Yeah.
in terms of sometimes, you know, you may spend time and nothing comes.
Mhm.
Just
Yeah.
don't
Go.
despair.
Yeah.
Stop it, go do something
Yeah,
else, and come with new eyes and
Yeah.
do it again. It's not how you say, these are not inventions. These are really things that work. If you let your brain rest for a while and you revisit something, there it can appear to you. So it's don't give up at the first encounter with the images, okay, if it doesn't work out.
Yeah.
Yeah.
In the same token, you know, I think for the when I mentioned the responsibility, there is one thing I really don't like in EEG is when you say sharply contoured. I hate this expression because it is a spike or it is a sharp wave. Sharply contoured means I don't know, I delegate this, I just let go. Don't do this with the MRI. Either is a lesion or it is not. And so that is where you have to commit. And frankly, we always commit and rather below and say, I don't know, this is
I
not a
don't have
lesion.
confidence, exactly.
Don't count on this.
Yeah.
So rather than speculating and putting at risk the whole thing.
Yeah.
So that's another suggestion we have, specifically if you're at the beginning, be extremely careful.
Yeah. If you have questions, cases, you know, like Zeke showed us, I mean, we are available. You can always reach out. We look at many cases from many places, and sometimes we can help. Not always, but sometimes we can help. Definitely.
Thank you very much.
Well, it's a pleasure to see that there are people who do use these algorithms, and you know, who can and who are present and who have questions. It's good to see young faces. So maybe something we would like also to tell you that could be useful to you. Emma was at our course, and we had these case reviews, and people liked it because they would go through the cases and discuss it. And what we have decided is to make it like really open to people without having to go to a course for a particular time. It's that we are preparing these cases for review, and they will be available on the AES, American Epilepsy Society site. You don't need to be a member of the AES to be to have access to the course and the didactic material. You just have to log in and I think register for the course, but at the end it's $0. Like, you don't pay, but you get the permission to go to look at these cases. And we are preparing them with case history, and then a viewer with the T1, the flare, exactly like what Zeke showed us, similar to ITK, and with the lesion label available. So you can kind of make your mind, click in different places, and at the end, if you want to double check if you were right or not, you go and you load the lesion label, and the lesion has been segmented. So that's a good didactic material to, if you don't have so many cases to review in your institutions, at least it can teach you a little bit these characteristics in number of cases from easy to difficult to detect.
It's about 100 FCD. I think.
Yeah, I think 80 or so FCDs. We also have other
TLEs,
cortical malformations and temporal lobe epilepsy cases.
it's about 200 altogether.
So this is not yet finished, but at some point, I think in the beginning or in spring of next year, it would become available as a module, didactic module on the American Epilepsy site. So you're welcome. Obviously, I think it will get, I don't know, somehow known to people, but you can definitely, it would be useful if you want to look at these cases. Yeah.
Okay, once again, thank you very much, and
No problem. Reach out
and it was
anytime you
a pleasure
want.
to have you here.